Greetings, everyone, and welcome to the Frontline Health Project HSR virtual satellite session on evidence and advocacy to advance community health policy programs and systems, a political stepping stone to universal health coverage. My name is Charlotte Warren, and I'm a senior researcher at Population Council and the director of this project, which seeks to advance community health system metrics, monitoring and learning to improve the efficiency and performance of community health systems. I'm joined here today by colleagues from Population Council, Last Mile Health, Zanmi Lasante, and Johns Hopkins Bloomberg School of Health. Next. The objectives of this session are to present evidence and policy progression efforts to support community health programs, to provide an understanding of key factors influencing community health worker performance incentives, to describe how the engagement of political forces was intertwined with research and advocacy methods, and to deliberate the roles that measurement, research, policy, and advocacy play in developing, implementing, and monitoring national community health programs advancing towards UHC. Next. For the first hour of the session, you will hear from 4 frontline health worker project staff and partners about the research and advocacy efforts around the project. Afterwards, we will have a group discussion moderated by my colleague, Dr. Pooja Shripad, exploring key questions sparked by the presentations which tie into the objectives of this session. So now I'd like to introduce our presenters. First, you will hear from Dr. Timothy Abuya. Tim is an associate at Population Council based in Nairobi, Kenya, and he will present work from the Frontline Health Project's Quality of Care study in Kenya. Next. Then we will have Dr. Smisha Agarwal from Johns Hopkins Bloomberg School of Public Health, and Smisha will present key findings from the Frontline Health Project's incentive study in 4 countries. Next. Then you will hear from Dr. Alain Casseus, the project manager at Zanmi Lasante in Haiti. Alain will present findings from the project's policy study in his country. And lastly, next, we will hear from William Walker, who's the Deputy Director for National Community Health Systems at Last Mile Health in Liberia. William will present Liberia's community health system reform. So let's start with Tim. Over to you, Tim.
Good morning, good afternoon, everyone. Thank you, Charlotte, for giving me an opportunity to discuss some of the findings from Kenya. I'll take you through some of the findings around quality of community-based maternal and newborn health services in Kenya and derive some of the implications for achieving universal health coverage. Next slide. So this work is part of a broader frontline health piece of work that we aim to generate evidence on performance metrics. Particularly, this work focuses on issues of service quality and experience of care that's provided by community health workers in the Kenyan setting. Next slide. So why focus on community quality of care provided by community health workers? Now, in Kenya, they are known as community health volunteers because basically they work on a voluntary basis. So we do know that quality of care is a critical driver towards achieving UHC. And since community health workers are the first point of contact between communities and health systems, it's important to examine to what extent they provide, what type of quality they provide when they visit households within their own setting. We also know that quality of care, especially postnatal care among community health workers, is poorly measured. So the aim of this study was to assess the technical and experiential quality of care that is provided by community health workers for women and their infants between 0 and 60 days old. Next slide. So before we go into the details of the type of services that we explored, I'd like just to give you a glimpse of the Kenyan health system structure. So Kenya seems to be looking into the idea of enhancing primary healthcare system. And at the community level, there are community health volunteers that serve a population of about 5,000 people in one community health unit. They basically provide community health services as per the Kenya Health Strategic Plan. And for those cases, and they provide counseling services and basic health education. In some instances, they also provide basic family planning services and link community members to services. And those services are then provided either in level 2 and 3, which are health centers and dispensaries, which serve about between 10,000 to 30,000 people. And in case you need referral services, then you'll have to advance to level 4 and level 5, moving upwards for specialized services. So we know that in the Kenyan setting, primary healthcare services are obviously provided by the community health worker or volunteer in that respect, as well as primary healthcare services in health centers and dispensaries. They present the backbone of healthcare system within the country, and therefore very crucial and critical to advancing and achieving universal healthcare coverage. Next slide, please. So how did we do this? So we conducted a cross-sectional mixed method study to examine the technical and experiential quality of postnatal care services provided by community health volunteers. In Kenya, as I said earlier on, we refer to them as community health volunteers. And in this presentation, I'll be referring to them as CHWs. We therefore measured the technical quality using a 25-item checklist covering 4 postnatal care counseling domain, which includes infant warning signs, maternal health warning signs, essential newborn care elements, breastfeeding, and we also examined experiential quality of care using an 8-item communication quality checklist. And we had some qualitative discussions with community health volunteers and focus group discussions with postnatal care mothers. So in order to examine the technical quality of care, we had community health volunteers observed by trained research assistants when they did their usual visits to the households. We did observe about 148 observations across 2 counties in Kenya, one on the coastal region in Kilifi and one on the western region of Kenya, that is Bungoma. After observations, we then followed up these clients within 2 weeks to just get the experience of the visit they had with the particular CHV that was observed in the previous 2 weeks. So the findings I'm going to present today are based on both matching the observed visits together with follow-up visits within 2 weeks. Next slide, please. So how did we assess the technical quality of care? We did this against the Ministry of Health guidelines. So in Kenya, postnatal for women and their infants are supposed to be visited by CHV at least 7 times after birth. So they are supposed to be visited. Contact 1 is supposed to happen either within day 1, 2, 3, and 7. That's contact 1. Contact 2 within 1 month. Contact 3 within 6 months. Contact 4 within 9 months. And contact 5, obviously, it follows the cohort of 12 months, 18 months, and 25 months as the child grows. For the purpose of this presentation, we only observed mothers who are children either between 0 and 28 days and up to 60 days, but they may not necessarily have been visited either before or within the same contact period that is addressed in the Ministry of Health guidelines. Our focus is largely on either day 1, 2, 3, and 7 of the contacts they had with community health volunteers during the same period. Next slide. So I'll not dwell on this slide much, but basically it shows you all the 25 elements that we examined. As I mentioned earlier on, danger signs for the baby, essential newborn care for the mother, as well as aspects to do with care. The next one. We also examined these issues of communication, and the questions were, did the CHV either explain the purpose of the visit or greet the client or answer questions simply? And these elements are examined as part of communication between CHVs and the mothers. Next slide, please. So I'll now take you through the results. And in summary, we see general low technical quality scores averaging about 26%. So these elements are derived from all the aspects that I've just shared in the previous 2 slides. And CHVs appear not to counsel mothers, talk a lot about danger signs for both the mother and the baby, and very low scores for essential newborn care discussions and counseling. But they do very well in breastfeeding and discussing the elements of breastfeeding from with the mother. And overall, the last elements of the slide shows the overall scores about from 0 to 25 elements, scoring about 26% across board. Now, in the next slide please, I'll now share with you the interpersonal communication derived from the elements that I presented earlier on, and they do very well in terms of interpersonal communications, averaging about 80% across the contacts. Next slide, please. So some of the qualitative discussions we had with CHWs and caregivers of the mothers that we observed suggest actually that there's very good rapport that's created between CHWs and mothers, which is a recipe for trust, a currency for enhancing care. We also see the second quote there representing how well they do in terms of breastfeeding. As we saw earlier on, the scores for breastfeeding were quite high, meaning, you know, there's a tendency of CHWs to talk to mothers about nutrition at that age. But we saw, and I'm going to show in the next slide, that they are often not able to have the right tools for work. So when we looked at regression models, we saw higher quality scores, which were associated with older mothers, longer visit duration, and CHWs who carried at least 3 of their job tools that they use on a daily basis. We also saw significantly lower total quality scores, which were associated with visits when an infant was identified as unwell, meaning there's a gap in terms of ability to examine that baby properly and counsel the mother adequately at that point in time. We conducted a sub-analysis of individual job tools, which further showed that CHWs who carried the handbook, which is typically the content that they derive the information from, had total quality of care scores that are about 3 points higher than those who did not have the handbook, meaning the handbook actually was quite handy in terms of providing information and reminding them of what to do and what to ask. The same was true for CHWs who carried this job aids, and carrying neither the referral slip nor visit schedule registry were associated with lower total quality scores. So in terms of things that enhance ability of CHWs to provide good quality care, they need to have the handbook ready or the materials that they use ready to act as a reminder for their normal daily routine schedules for the visits. Next slide, please. So what do these findings mean? We have seen that there are gaps in the technical quality of CHV, which is characterized basically by poor targeting of content. We actually did by contact visits, and we show that they don't actually target the content that is appropriate and necessary, depending on the infant's age, which means either they need frequent updates on the content of counseling. We also have seen that their total quality scores are influenced by availability of job aids, illustrating the need to ensure that CHWs are equipped with essential supplies, supply tools. And this can be digitized because in the era where they can easily be available on digital platforms, this will be very useful for CHWs to be able to use as they visit houses instead of carrying the big handbooks. So due to the challenges of its supplies in terms of tools of trade, we have seen that the inadequacies in implementation of community strategy limit access to the basic supplies and update. And this has implications in terms of the nature of quality. And as we saw earlier on, quality of care is critical in order to increase access and coverage to services and therefore enhance and achieve universal health coverage. We can enhance or can build on the positive communication that we've seen with community members, which, as I said earlier on, is a recipe for building trust, which is key to increasing access to services under the primary healthcare agenda. Next slide, please. So in conclusion, I would like to say that there are obvious gaps in the technical quality of postnatal care that's provided by CHWs at community level. But we can leverage and promote the positive elements of experiential quality of care, which will go a long way in terms of improving relationship and therefore acceptance of services provided there, and possibly even improve referral to higher levels. And we've seen even from our qualitative discussions with them that CHWs play a very important role in the primary healthcare network in Kenya in establishing community facility linkages and expanding coverage of services at that level. Therefore, improving their quality of care will be instrumental in increasing UHC at primary care level. So I'd like to stop there, and if there are any questions or comments, perhaps we can take it up from there. Thank you, and over to you, Charlotte.
Thanks, Tim. I think we'll move. Do we want to, has anybody got any clarification questions? Please let us know, or we can move on to Smisha and have questions at the end. Smisha, I suggest you continue.
Okay, great. So good morning, everyone, or good afternoon, good evening, wherever you are. And I'll be talking about a multi-country study that we conducted to understand incentive preferences of community health workers in Bangladesh, Haiti, Kenya, and Uganda. And this was done in collaboration and with the leadership of Tim and our colleagues from Bangladesh, Uganda, and Kenya, as well as Haiti, several of whom are on this call, so and can help address any questions you might have. Next slide, please. So just to start with a little bit of background, the recent WHO Community Health Worker Guidelines outline that practicing community health workers should be remunerated for their work with a financial package that is commensurate with their job demands. Though it made this recommendation, the guideline also identified the lack of information on what this remuneration package should look like, and what is this balance of both financial as well as non-financial incentives that healthcare workers should have. However, historically, community health workers have been considered volunteers, and more recently, towards universal health coverage, there is the emphasis to ensure that these healthcare workers are adequately supported with appropriate training, advancement, as well as remuneration. Next slide, please. And so we conducted a study to understand this balance. What is this balance of incentives that would help improve the performance as well as retention of community health worker programs over time? And it was done in close collaboration with the ministries of health as well as USAID country offices and UNICEF offices in each country, as well as with Pub Council in Kenya and Bangladesh, and Pathfinder International in Uganda, and Zanmi Lasante in Haiti. Next slide. We followed a two-step methodology. In the first step, we focused on identifying what these incentives look like. We have a sense of what they should look like from existing literature, but we know that there are a lot of variations. And so we spoke to community health workers, their supervisors, as well as policy level stakeholders to identify that balance of financial and non-financial incentives, which are desirable from the healthcare worker perspective, but also practical, pragmatic from the policy level stakeholder perspective. And next, we administered a discrete choice experiment, which I can go into a bit more detail. The study was completed. Both the phases were completed in Kenya and Uganda, and manuscripts should be available in the next couple of weeks, actually. And then phase 1 was completed in Bangladesh and Haiti, and we discontinued phase 2 because of COVID. Next slide, please. So going a little bit more into the details of phase 1, we used a nominal group technique where we identified community health workers to identify their top incentives. And we spoke to them not just about incentives, but about different aspects of community health work that we know are important. Factors that are related to their motivation, performance, and retention, their relationship with the community, their relationship with their healthcare facility, as well as their understanding of governmental support in supporting the community health worker program. Next slide. So at the end of phase 1, we had a series of attributes Attributes can be things like salary or transportation, identification, things that community health workers considered valuable, as well as levels of these attributes. So for example, for transportation, the levels might be, we want transportation refund, or we want bicycles, or we want motorbikes that would help support our work. So those are levels of attributes. And we took this list of attributes and levels of attributes that were prioritized by community health workers and discussed them with policymakers and other stakeholders to get a sense of, are these realistic? Because we didn't want to be testing unrealistic attributes in the second phase. So for example, if community health workers suggest that a salary range of X to Z would be desirable for them, we ensured that this range was also something that policymakers felt was realistic for them. And then we conducted an experimental design with choice sets. So we gave each of the community health workers 12 choice sets where they were asked to choose between two job scenarios, and I'll shortly present what those look like. And they had to choose. And so based on this, we used a method called discrete choice experiment, which utilizes random utility theory to understand what attributes were prioritized by community health workers. Next slide, please. So here is an example of what these attributes and levels of attributes look like for Kenya. A monthly stipend ranging from 2,500 shilling to 5,500 shilling, a variety of income generating activities, identification, availability of tools, which was a combination of supplies, pharmaceuticals, education materials, means of transport, and recognition. And before I proceed, I have to say that things like identification or tools should not be thought of as incentives. They're very much part of what anybody's job should provide for. But in the case of community health workers, these are not often provided, and therefore they become disincentives, or they become factors that demotivate community health workers. And so we did include them as priority areas in this study. Next slide, please. So moving on to an example from Uganda of what the attributes and the levels look like. So you see that there are significant overlaps, like identification, tools, transport, recognition, and stipend with the Kenya study. But the options are quite different in the case of Uganda as compared to Kenya. Next slide. And then an example of what these job scenarios look like, or how the DCE questionnaire is administered. So we, on the image on the right with job A and job B, has different options for stipend, identification, training, tools, transportation, recognition, and workload. And community health workers had to choose between whether they would pick job A over job B. So if you notice that job B has double the stipend of job A, but it has no transport. Job A has transportation allowance, and job A also has career progression. So really, the core of the study is we understand that given government per capita health expenditure, we know that governments have a certain threshold of expenses that they can invest into community health systems. And community health workers are traditionally thought of as volunteers. So the question is that in lieu of salary, in lieu of high wages, would community health workers, would alternate sort of job incentives make up for that loss of salary that community health workers have? Next slide. And so here are some of the results. Community health workers did prefer higher salaries, which we anticipated. However, it was not identified as the most important incentive. Method of transportation in Uganda was identified as the most important incentive, followed by identification, refresher training, salary, workload, and recognition. And community health workers were willing to accept a decrease in salary by 31,000 shillings for IV batches. And they were willing to accept a decrease in salary of 85,000 shillings or $23 for branded uniforms. So we see here that they were willing to switch a financial incentive for a non-financial incentive. Next slide, please. We can move on to the next slide. So results from Kenya also, we recognize that transportation was in fact the most important incentive, followed by working tools and a monthly stipend. And income generating activities were identified as least important. In Kenya too, community health workers were willing to accept a reduction in salary for an incentive package that provided identification. So I think that's actually surprisingly a common theme and a common sort of finding in the willingness to pay between Kenya and Uganda, but really sort of noting that identification. So I didn't provide much of a background on community health systems in these two countries, but Tim spoke to that in Kenya. They're not considered as government employees, which means they're not, they do not receive the normal protections that government employees receive in Kenya and Uganda. But in Bangladesh, community health workers, the two cadres that we spoke to, are considered formal government employees. They receive pension packages and so on. And so identification as a government employee was considered very important in Kenya and Uganda. So next, I want to move on to some of the just general findings, cross-country findings from across the 4 countries. Next slide, please. And we identified some common themes across compensation, transportation, empty promises, working tools, identification, and recognition for their value and work across the 4 countries. Next slide. The first is that not only is thinking about what type of incentives is important, but understanding how they'll be paid and addressing the barriers to ensuring that these payments are being regularly made is really important. So take, for example, this quote from Kenya, where the community health worker says, the first thing is when we are trained and sometimes promised to be paid after good work is done, and they end up not paying us, and that reduces the morale to work. Next slide. Similarly, community health workers consider transportation to not just be an incentive, but to be vital to their work. Can you move on to the next slide? So I like particularly this quote from Haiti, where they said, I personally climb many mountains, access is difficult, but if we could afford a motorcycle ride or even a horse or a mule, it would be important. So they really see this as being critical to the function they perform. And it's something that, given the terrain, needs to be adjusted accordingly. Next slide. So several years ago, there was a study that focused on the disincentives for community health workers. And we certainly identified a lot of that, is that when promises are being made to the community health workforce and they're not being followed through. We saw several instances of that across the 4 countries. Let's take this quote from Bangladesh, where community health workers are considered a formal cadre of workers. We're passing our working life through frustration, tiredness, and failure. We want technical rank. In 1998, our Prime Minister promised we would get technical rank. However, 21 years have passed and we haven't received any of it. So these are healthcare workers who've been working for 30 or more years, and they are close to being retired without sort of that formal recognition that they expect, or that the government has promised at some point in time. Next slide. Across the board, we saw provision of working tools. Again, I should emphasize that we speak of them as incentives, but in the case of community health workers, they're very much the basics of what need to be there. And a lot of what was highlighted was having access to raincoats, medicines. There was a lot of information, a lot of quotes from healthcare workers where they said that when they don't have access to medicine, not only can they not treat the community, but they also lose the trust of the community, and the community stops to see them as a valuable resource. Bags during rainy seasons, access to guidelines, something very basic. And as Tim pointed out in his study, that healthcare workers who do have guidelines or job aids do tend to perform better. Umbrellas, gumboots, raincoats from across all the countries that we conducted the study in. Next slide. So some form of identification, I've already spoken to that, but this is again a very practical request. I think we should be provided with something to identify us when we walk into the community. People may take advantage, pretend they are CHWs in your name, which might land you in problems. Next slide. And so more around, and then finally recognition or career progression. They say that we are well trained, but we have nothing to present that fact. We have never received any document that suggests we completed any course. Let them give us certificates that show us that we were trained to carry out the roles of a community healthcare workers. Next slide. And then finally, and this is, I think, one of the themes that we're pursuing with more in-depth analysis, there are a number of justice issues where I think the question that it got us to is that these community health workers are often volunteers. They too are the lowest, the most marginalized rung of society, and we're expecting from them great altruism. And yet often they themselves, through that altruism, are being taken advantage of. So this quote from Uganda, most times as community healthcare workers, they call you up urgently and say, hurry up, come here. And sometimes you don't even have transport. You finished the work, the training, you've done everything. And they tell you, my dearest greetings to everyone at home. You left home with debt just because you have to fulfill the needs of the community, because you work for the community to fulfill their needs. You cannot miss the training, so you invest money in yourself and you have borrowed it. So I think this really sort of highlighted, that these healthcare workers for transportation, especially there are several NGOs that work with community healthcare workers, short-term training programs where compensation may not be discussed, so there is no formal documentation of compensation, and they can really be taken advantage of. Next slide. So in summary, I would say that there is a balance of incentives is critical for community health worker performance and retention. Financial compensation alone does not drive motivation. There are a number of other factors. As we think about what these compensation packages should look like, we really need to think about how we can remove barriers to ensure that whatever the compensation is administered in a timely and appropriate way. We also recognize that transportation and identification are some of the most important factors. And as I've mentioned before, they should really not be thought of as incentives, but as just the basics of what needs to be there to ensure that healthcare workers perform their role, like a stethoscope for a doctor, right? Like it's their basic tools that need to be in place. And I think more studies need to be done to understand sort of what this balance of incentives and disincentives are, and really cost them out so that we can understand pragmatically what government resources can actually bear in the long run to support cadres of healthcare workers in country. Thank you.
Thanks, Michelle, for the presentation. We just wanted to pause for a minute to see if there were any questions about the presentation, clarifications that are in the audience. If not, we can move along and then ask a number of questions at the end. So next we have Alain. So please take it away.
Thank you, Smisha. Hello, everyone. I hope you're all doing well wherever you are. I'm going to present and very briefly the findings that we had while we're doing some work with Zamila Santé, which is an organization in Haiti, in Population Council, concerning the consequences of external shocks on community health systems in Haiti. Next slide. So some of you may or may not know the history of Haiti, but as the country is today, it's the result of context dating all the way back to the colonization. It was a very rocky beginning for the country, especially given that it was one of the first times that a country of slaves rebelled and became free. And we can say that we paid dearly for that independence. And also, we face many issues, not only internally, but also with external politics over the years. And at some point, the community health system became existed in a way, started existing during the occupation of the United States in the 50s, because before that, everyone had to come all the way to the urban areas or the metropolitan area. And it's from the 50s that really the rural areas started having care. And in the last decades, we had a great many natural disasters, a lot of storms, a lot of there were the earthquakes, the droughts, a lot of other issues that really stressed the system as it is right now. Next. So in Haiti, as it is in many African countries, as it is in many countries that are part of the South, community health is the first line of care, mostly because naturally it is free, free for the community, free for the habitants. And it's also, it has a good proximity. So it's local, meaning that it sidesteps the barrier of having to pay for transport to go get care. And a good part of the community health tasks are to educate the population in order to prevent certain diseases that could be prevented with better knowledge, better practices. And also it helps with surveillance and monitoring for epidemics or any other issues that may present in the community. So these community health workers are usually the very, very first link that the person in the community will have with any form of care. Next. So how do all those constant social and political issues, which are also compounded by environmental stress, how do this affect the community health system? Next. Next, please. Okay.
Hey, Alain, are you still with us? Are you able to see the slide?
Yeah, I'm here. Sorry, internet issues.
Oh, it's okay. Go ahead.
So, yeah. So what we did, we used qualitative methods in order to assess this. First of all, we made some interviews with policy and program stakeholders at the regional and national level, and also at certain institutional levels. We talked to CHWs, their supervisors, and nurses who supervise those community health teams. We also did a desk review of greater literature and national policy in order to determine a timeline and the types of shocks that presented during the past years. And then we did an analysis of all this data using in vivo. Next. So as a result, especially from the desk review, we found that there are three types of shocks that were identified. First, there were all the political shocks, which you will see in this timeline in red. There were the natural disasters and the disease outbreaks. The political issues were far more frequent because from the inception of the country up to this day, there were always issues related to the democracy, as everyone wants a piece of the power. And unfortunately, this has not worked well for us. And the natural disasters have often been the most, I said the most major issues that we've faced, especially cholera, which everyone knows about. Next. So what are mostly the effects of these shocks on the health system? So in the case of political issues, especially political transition troubles, we often have, and we still are having currently, right now at the moment, a lot of unrest, a lot of increase of violence because there's less control and there's not enough police force to help control everything. Which in also for the natural disasters were issues with infrastructure, issues with food insecurity, similarly with disease outbreaks, and all these factors will create especially delays in how care is being given locally, but also affects funding, it affects service delivery at the institutions also. It affects issues of governance. For example, when there ever is transition, it's up in the air whether who's the health minister or not, who's going to still be at the district level or not, and all this creates a really vague structure of governance that no one knows what to do. And on top of that, well, at the bottom, we also have all other issues that are related, that still exist, which are especially the poverty and the insecurity that is rampant in the country. Next. In the case of political unrest, they've caused a lot of delays, as I say, in the community delivery, and the CHWs, as well as I'd say even us at the institutional level, we have often had issues to actually get to where we need to go. Vaccination is done mostly at the community level, and often there are blockades. CHW cannot go to work, and donor funding is also delayed and affected because a lot of the funding that we receive in the country goes to the government, and whenever the government is having issues, those fundings are often put on hold or diverted, which causes issues at the end point because the CHWs cannot be paid. They can also not get the supplies they need to do the work that they're doing. Thanks. So another consequence of shock that I can speak about is the issues related to referrals. And similarly to the CHWs not being able to go provide the service, referrals are important because for certain cases, especially emergency cases, women in childbirth, not being able to refer the patient not be able to get to the hospital or to the health center puts that patient's life in danger. And this often happens whenever there are riots, whenever there are blockades, stopping the patient to get to where they need to go. And one other thing also is that during some of these shocks, resources will be decreased on the field. Decreased because the supply chain is broken. It's difficult to get the supplies where they need to go. It's difficult also to find ways to mitigate this issue. And of course, this increases the burden of the work for the CHWs because if there is, for example, an outbreak, they will have increased education to do on the specific issue, for example, COVID. They will have extra risks they will be taking during the pandemic because they will be going directly on the field, and all this affects their work, affects especially their mental health and their well-being. Next. As I said before, yes, CHWs are often put at risk, not only physically, but they're also mental issues that are related. But they have also shown themselves to be very devoted, very committed to their work. And despite all this, the CHWs have been able to keep their morale, keep going no matter what happens, even with without a salary, even with a salary that is insufficient for the work that they're doing. Next. So this comes back again, as I was saying before, to the resilience of the CHWs. They've been shown to be very motivated for the work they're doing, and one of the motivations that they've had was the engagement of the community itself. Not necessarily through gifts, not necessarily through monetary rewards, but simply through the encouragement they get by how grateful people are for the work that they're doing. And we've also seen some types of innovation, I would say, created through the crisis, because somehow we always have to find workarounds to provide services to the community. Next. Some recommendations were proposed by the CHWs, and the first was that their importance should be recognized. Recognized not simply a question of salary, not simply a question of rewards, but simply a question of saying thank you at the governmental, at the regional, and even at the institutional level, seeing them as an integral part of the system. Unfortunately, we have had this issue institutionally in many of the health centers and hospitals where they feel that the CHW cadres are completely outside of their system, completely not part of the health system, which is not true. It's important that funding be increased for community health because funding is almost nil, I'd say, in this case for this part of the health system. And the MOH has had to rely mostly on partners and external donors to support CHWs. It needs to be part of national funding because at any moment, for any reason, donor funding may decrease or disappear completely. And the capacity building for CHWs is also very important. We have been working on that a lot at Zemila Santé, trying to certify and complete fully the MOH curriculum in order to have a maximum number of CHWs who are truly ready to do the work. We call them, at that moment, we call them ASCPs, which means they are polyvalent community health workers. And which would include, of course, disaster preparedness, which is something that is still lacking in most of the curriculum for these cadres. Next. In conclusion, so all of these shocks, political transitions, natural disasters, these outbreaks, they continue to influence the community health system. Even to this day, we've seen how it's been with COVID, how it's been with the current riots. But nevertheless, the workers in the system, the CHWs, the nurses, the supervisors, have proven to be very resilient and wanting to keep working in the system. And I can say that when I say they play a significant role in primary healthcare, it's because they are the first line of health for most of the population, which is very poor. And it's important that we remember that the essential package that the MOH wants to talk is one of the key points for good coverage of healthcare, universal healthcare, if you can say it like that, for Haiti. That is all. Thank you. If you have questions, please ask them in the chat. Out.
Thanks a lot, Alain. I think what we may do, if there's no questions at the moment, we'll come back to questions for the presenters together. And let's move on to William Walker from Last Mile Health.
Let me say good morning, good afternoon to all. My name is William E. Walker Jr. again, presenting on Liberia Community Health System Reform Journey. So to talk about system research of the differences between what of a particular research and how to do a particular. looking at an example of Liberia as an example. Next slide. So today's presentation will focus on what we call the what and the how. So as you may all know, mental health worker programs have been shown to be highly effective in saving lives, expanding access to health services, and generating strong investments. So there are a lot of documentations that describe what to do in community health. For example, we have the WHO guidelines that speaks on those technical design questions about which criteria we should use for CHWs and what should be the durations of pre-service screening. So all of those answer the what. But in order for us to be successful, we want to deep dive into using Liberia as an example, answering the how to these questions. So even though we have people that tell us how to do it, what to do, but the how to do it using Liberia as an example is what we want to deep dive. So we are having a body of resources about what to integrate in skill, but not how. But once in this presentation, we will be able to deep dive on more how and how Liberia will be doing it. Next slide. So let me try to reflect on this community health system reform cycle that we use, especially within LASMA and countries as Liberia also have adapted, learning Liberia did. So what we view the how, looking at this community health reform cycles into different stages of looking at what we call the problem prioritizations, coalition building, solution gathering, design, readiness, launches, management, and learning. So all of these make a cycle. Once you reach at the end, it all starts again. For last mile health, we have been using this to understand the country existing community health systems, especially in Liberia, looking at all of what we've been doing. The community health system reform cycle can even be applicable to a whole system, like a national community health programs, or even a part of a information to improve the community systems. Next slide. As we spoke about the how, we went to look at country, and today we choose Liberia as an example. For example, Liberia from 2007 to present. If you notice the issue of community health workers programs in Liberia between 2007 and 2015, there were fragmented programs all around the country. What do we mean by fragmented? That means every programs or every partners were implementing community health program by their own will. There was not a standard policy or strategy to guide partners. All of the process were led by partners. But lesson learned from Ebola, by 2015, they got to use this reform cycle to be able to implement a unified community health assistance program across the country. One advantage was every partner who implemented into the country now follow the guidance of the Ministry of Health. There were one data systems and no longer partner-driven data systems. There were one way of quality improvement and performance management, followed by all partners adhering to the government protocols. Next slide. Just a snapshot of what the community health policies of Liberia look like, coming together under that one national policy and programs. So the main thing into the new community health assistance program in Liberia was, no matter who you are or what the partner is, community health workers programs should only go these 5 stages. There will be recruitment of all community health workers with a standardized policy. All of them will be trained into a standardized model. We all equip them with the necessary drugs and supplies they are needed. They will be supervised and supervised by a cadre of supervisors. And lastly, they will have to be incentivized as a way of motivation based on lesson learned. So this was part of the Liberia National Policy on how they did it, looking at an example of Liberia best practices. Next slide. Let's deep dive into the how. We have all of what to do, WHO guidelines, what to do, community health worker programs. But let's an example of how did Liberia move on to have a successful community health worker programs. For example, if we look at the reform cycle starting from the problem prioritizations, moving on to the coalition building and solutions gathering, Liberia by 2012 to 2014, right before the Ebola outbreak, Ministry of Health started to identify that Liberia program was fragmented and they cannot continue on like that. So what they did, they have identified the problem of what we have to solve. So because of that, they decided to build coalitions with all champions within the programs, people who were going to champion the program at national level. So they also found out that they have to gather some evidence base, like for example, pilots taking place across the country. There were some good pilots across the globe, so they were all able to gather those evidence around 2015. Those programs have been gathered. They were able to do a design and readiness by 2016. So the design was coming together to make a standard strategy, launched the strategy by 2016. And by 2017, 20, the launch and governance part of the program started. So the issue of the Ministry of Health started to govern the aspect of what pilots. People have started to learn about what was the best practices and how to improve the programs. So we will deep dive into how that was done at the program reform cycle. Next slide. Let's categorize this into three. For example, number one, the policy and planning stage. So the policy and planning stage is government committed to solving that health equity gaps and design a local adapted community health system to close that other gaps. So in Liberia, there were 29% of the populations that didn't have access to that basic skill. So based on that, we firstly advocated to prioritize that since the problem of access to basic life-saving skill, we were able to design a community health roadmap conveying all key stakeholders. So lesson learned is that do it alone into this first stage. So using the community health reform cycle is that you must involve key stakeholders in the problem prioritizations. You must bring all those key stakeholders for coalition building. So like once the key stakeholders were on board, we started to set a subgroups. For example, we have a subgroup for recruitment, for training and supervisions, health system. So deep dive into how are we going to do those good policies that is into place. And lastly, we have to find a solution. Some of the solution gathering was that we have to look at those best practices that were done by other partners in country. We also have to look at the people in other countries of what they were doing. So to be able to implement a good community health program, the first thing is that we should remember how we're going to do it is by using the policy and planning stage firstly to move things forward. Next slide. The next phase is the issue of planning, deployment, and launch. So the government and partner form a coalition to work together to mobilize resources implement and support the scale of the community health systems. So once we have done the problem solving of how we are going to do this, we were able to design a policy and program design tools. So like we said, by 2016, there were a national service policy and strategy to govern whoever want to implement a community health worker programs in Liberia. All of those were disseminated in every level, starting from national to districts in Liberia. There were a lot of tools developed, including for training to guide the process, health information system, on-one reporting systems, job aids, and all of those standards were developed to guide the programs in every of the country. On the same reform cycle was we were also able to look for what are those resources needed to run the program? Do it cost to run the program over the period of time? How do we advocate with partners? So the next phase was in those reform cycle was mobilizing resources, equipment, and partners and donors, just to ensure that the program is successful. So lastly, like once the program was launched, the issue of revisioning, we started to ensure operational quality and rollout. So those SOPs and guidelines were started to be launched, were followed, started going in the field to ensure SOPs and guidelines were followed, community engagement meetings started to take place. So in this phase, it answered how did Liberia ensure that they were successful in implementing an examples of a community health program. Next. Next slide, please. Yes, so to end this reform cycle, we talk about sustaining and evolving. So the community health system plan for partners to government ownerships was one of the ways to sustain. So in case, instead of partner leading the process, government now on board to lead the entire reform cycle. Government were now on board to guide the process of what partners does part of Liberia. So that long plan that made for financing and sustainability program, even though part of it was still challenging, but that standards were placed. For example, the governance of the community health primary health system, they were able to set up a division within the Ministry of Health. Division have in the operational plans of how the community health workers program was going to be governed on a monthly basis. And up to this year, those divisions are working with other divisions in the Liberia Ministry of Health to engage them so that at all levels, community workers are dealt with according to the standard policies. So they were also able to do review of program performance and improvement. So lesson learned with management, people have to learn on those what we put into the policy. We introduced what we call equality meetings to look at the performance of the 15 counties within Liberia. They also implemented research, did like the program per sessions to understand what community health workers think about the program, what the community think about the program, what national stakeholders think about the program. And they also implemented what we call the implementation of fidelity initiatives to say, with all of what we designed, are we actually going to put into the policy? We were also able to implement those research to be able to learn over the period of time. So next slide, please. So all of that started 2016, and now we are to 2021. So Liberia were able to use that reform cycle to have a successful phase of 5-year implementations. And as of present in this year, 2021, we are going back to current prioritizations and coalition building. So as of now, we are working with all stakeholders to ensure that we are back on the table, looking at what was the problem in the first 5 years of implementation. And this same reform cycle is going to be followed into a new phase of community health worker program in Liberia. Using this as an example across the country will always help you to answer how to implement a successful community health worker program no matter of what you have as a guideline. Let me say thank you from my end.
Thank you so much, William. That was a wonderful presentation in terms of thinking about the how. I think at this point, I have several questions that I can certainly ask our presenters. I just wanted to thank, first of all the presenters for sharing with us the wide range of evidence and policy progression efforts that you've all been involved with to support community health workers and community health systems. A few reflections. We heard from all of you. There were several themes that came up again and again throughout the presentations. We heard from all of you that community health systems and workers within and sort of part of that system are as critical stakeholders in our global effort to achieving UHC. So UHC isn't possible unless we have that community layer of the health system helping to deliver primary healthcare services in particular. We saw the importance of engaging those playing a role in providing the services, as well as the sort of support structures that are required to enable them to sustain high quality work and promote resilience in the long term. We also heard a bit about methodology and thinking about ways in which to either engage community health stakeholders in the process of research, the process of collecting data, as well as in the process of advocating within the context that they're working in for improvements within the system and the programming processes. And that this sort of experience of those involved may sort of allow all of us, and particularly at country level, to glean lessons that are lessons or approaches that may be useful in achieving the UHC agenda moving forward. Some of the wider themes that I heard coming out were around political process, the role of trust in the in terms of community health workers themselves, and that relationship with the community, and also this importance of the transition or kind of nature of collaboration between implementing partners or kind of the global non-governmental agencies with governments in terms of sustainability of these programs. And I think these seem to have varied a bit between community health, sort of the level of maturity and stage of a community health system and program. We heard from several countries. So I think this really gave us a nice snapshot into the challenges across the board. So I am happy to go ahead and ask a couple of questions to our presenters, and then I would encourage the audience members to think about some questions, and feel free to unmute yourselves once we hear a first round of comments from the presenters. So just to reflect a bit, Tim, in your presentation, you spoke a lot about measurement, and you spoke about the importance of measuring quality as a part of achieving or moving towards UHC. So I wanted to ask you to reflect a bit more on that. How do you think, especially experiential quality, can be measured, and in what ways, what types of data you think would be helpful in that process that governments and programs can actually sustain moving forward? Tim, would you like to reflect on that? And then I can move on to the next presenter.
Thank you, Pooja. Yes, an interesting question to think about. Experiential quality of care can be measured in a number of ways. One is because investing in observations can be very difficult and can be very expensive. You can only do that in a research setting. Particularly when you have funds enough to be able to observe, like we did, at least 3 visits per CHV to be able to understand the content of interaction between CHVs and the mothers. So one way to do that is actually through, for example, if you have in Kenya, you have community health units. You can actually talk to mothers who may have had experiences with CHWs, either in the community or as they come to the facility for services. Then you have a very short, 5 to 10 question tool that you can actually ask, what was your experience with CHWs, and very quickly you can be able to pick up if you had an interaction with that. Such kind of data can be easily collected either through existing structures. Like in Kenya, community health workers do on a monthly basis collect certain data on households and the experiences of and the care that on the illnesses that they come across and refer at the same time. But to be able to understand the interaction between community health volunteers or workers with moms or caregivers or community members, you need a very simplified tool that can be used to do that. Where that is anchored is a discussion that perhaps needs a little more thinking and context specific. But basically, for example, in Kenya, you can either have that, when a woman is referred to a facility, you can actually, using what you call an MOH 100 form, you can actually ask that woman, what was your experience with this with the CHWs, and that data can be entered into the normal DHIS2 system if that's practical. We do know that changing data or adding questions or data points in the DHIS system is usually a very long, protracted political process. But eventually, if we're interested in understanding the black box of that interaction between CHWs and mothers and see how best to support them, then I think it's a valuable tool to be able to build upon. Over to you, Pooja. Thank you.
Thanks, Tim. Just to mix up the order a little bit, William, you spoke about the community health reform cycle, and I think gave everyone a lot to think about in terms of how to sort of move from one stage to the next of that cycle. I guess two sort of related questions there. One is around if you can reflect in the Liberia experience around the challenges that you faced in this collaborative environment, stakeholder environment, as you worked through the policy process. And were there specific areas, in the planning or the deployment or the sustainability phases that you felt were more or less challenging? So that was one question. And then moving forward, if you sort of have any reflections on how others who may be considering using the reform cycle, what they should think about and consider in using when they use it.
Let me say thank you, Pooja, for the questions. So looking at Liberia's scenario, Liberia was one of the countries hit with the Ebola outbreak in 2014. So great lesson learned was community health workers were very keen in bringing stop to that outbreak. So all of the stakeholders saw the role of community health workers and what they did to ensure that Liberia were free from Ebola outbreak. So what was key is that the government have learned lesson with all what have happened, and one thing they needed to do was ensure that all of those stakeholders are on board. So one of the key lessons learned was that with all of what you are in, whether you are a donor or partner or whether you bring your money, we all have to sit around the table as stakeholders to come up with one policy and strategy that will guide us based on lesson learned from Ebola, the importance of community health work. So that coalition building of ensuring that all stakeholders were part of the policy process. It was not just government policy, it was all stakeholder policy. So we all agree that this policy will guide us, our implementations over the next period of years. So all stakeholders had an input, no one was left out of the table. That is one key lesson learned into the process. As you are starting off the process, ensure that all stakeholders form part of the process. And just to maybe advocate of your next question, for example, let's look at one good practice, what we call today the community-based information systems. For community health workers, you have one system of the Ministry of Health, the DHIS2, that report to the DHIS2, that you get all of the indicators from all community health workers. So you don't rely on partners to report. But once you have access to the DHIS2, whatsoever that is implemented, but whoever, which partner in every part of the counties in Liberia is reported into one system, and we all have access. So that part of reform cycle show lesson learned of once you use the reform cycle, these are some good practices that you get to ensure that we answer questions to those beautiful things that is written, what to do, like all WHO have put into a piece of paper. But if we use the reform cycle, it helps us to answer how we did it. If there were some challenges, and we all sat down as a stakeholder to look at our challenges together.
Thanks so much. Yeah, so the importance of really engaging from the beginning and taking into account the practicalities on the ground. So I think kind of related, since we got on the topic of Ebola and the importance of sort of highlighting the importance of community health workers in crisis, I want to pivot to Alain and ask you to reflect on the shocks. So I had a question around, maybe you can explain to us sort of how the different shocks may have posed slightly different challenges for community health workers. There seems like politics and policies have affected kind of the response at all the types of crises that you presented, but were there some crises that had more or less, in which community health workers were more or less resilient, and why do you feel that was the case?
Okay, thanks, Pooja, for the question. There were differences between shocks, although I must say that for natural disasters and outbreaks, like disease outbreaks, they were very similar. But political issues always affected the security of the workers and their mobility also. There wasn't this issue of mobility necessarily during natural disasters, except maybe if you count when there are storms, it may be difficult to reach an area because you can cross a specific river until that river has decreased, the flow has decreased in size. But yeah, so there are different ways that each affect. Yeah, like I say, mainly political issues is mostly security and mobility. Natural disasters, mobility somewhat, but still, if you were able to go around the issues, you could still reach the population. And for issues related to disease outbreaks, it's mostly being exposed to whatever pathogen is in the community. And given that a lot of them live directly in those communities, they are also potentially victims of these outbreaks. But you expect that with education and prevention, they may be less impacted than the rest of the community.
Thanks, Alain. And I think that's actually a really nice way to think about what this means for the pandemic context globally, to learn that actually community health workers are quite able and well placed to sort of help with response if they're supported in the way they need to be. And in thinking about support, Smisha, I thought it would be great if you could reflect on sort of a few things. So first I was thinking around, you mentioned sort of this balancing the trade-off, sort of balancing the different types of incentives, or as you said, not incentives, but kind of tools necessary for community health workers' jobs to be able to do their jobs. Did you notice any patterns that were similar or similar across the four settings that you can think of as kind of like top, most important or least important, or if you just sort of saw that certain incentives were more or less kind of mentioned. And then second, to reflect on the methodology itself. I think it's quite interesting for this audience, given it is sort of it engages political forces directly. It's asking policymakers, it's also asking stakeholders, the community health workers themselves, about what their preferences look like. And I think, maybe commenting on how that kind of methodology might be useful moving forward in the field.
Sure. So I think there were several common themes across the four countries. Salaries, of course, are important, as stipends, I should say, because in three of the four countries, the community health worker cadres are not formal government employees. And then transportation and identification were the other two areas that I think were identified as important across the four countries. I think this conversation is quite difficult in some ways, because on one hand there is the practical consideration of where are the government budgets coming from. Being a medical provider in India myself, I think about sort of the overall pay scales for government employees, and where on that hierarchy do community health workers fall. Especially, I think there is a lot of conversation now about a rights-based perspective to how the healthcare workers should be compensated. And I think that there is also the balance of balancing that rights-based perspective that yes, these healthcare workers should be adequately compensated, and they should have the protections from the government. That rights-based perspective with a pragmatic aspect of what can government budgets support, and what is the history of these healthcare workers, because there's a long history of how community health workforces came into being, and it's rooted in spirit of altruism, right? But at the same time, I think there's a gender perspective, because I often ask myself, if the majority of these healthcare workers were female, would we have thought of them as altruistic, volunteers in the community? So anyways, I guess it's just a fine balance of thinking about these aspects of what is needed to make community health worker systems right, given the cultural context of every country as well. And yeah, the methodology, discrete choice experiments, I think certain economists really don't consider this to be they have more reservations in the results to be presented. I think it's a great tool to have a conversation. We found it got a conversation going to put some objective numbers around how can we prioritize certain resources over others, because practically any incentives have a financial, have a budget line. So it really sort of helps put some numbers. And I think the results are really like a spreadsheet. It's a starting point for a conversation. It's not the answer to a problem. It's just providing some data. So those in positions of decision-making can use that data to then make a pragmatic decision.
Thanks, Smisha. Yeah, that's really helpful, and I think interesting for others moving forward, and to sort of what the limits are, but also how it can be used in these processes that we know are inherently political in all of our contexts that we sit in. Are there any questions from the audience? Do feel free to unmute yourselves, or I can unmute. If there's a way I can unmute everyone, I would like to do that. But feel free to ask any questions at this point if you have any for our panelists. I think if there are no questions, I think we can just maybe go to the next slide and then just have a quick wrap up. So yeah, I would like to thank everybody for attending this session. I know this is a bit tricky when we're around the world, many different time zones, and it's difficult to stay on an online platform for long periods of time. So appreciate all of the everyone for attending this session. I hope it was informative, and feel free to contact any of the speakers with further questions if you have any, or us at the PUP Council. We're happy to have further discussions around community health moving forward. So with that, I will close the session. Thank you all for attending.